There we go. Okay, guys, just so you know, I am now recording this session. I don't know why the record button didn't come up the first time. So I'll post this as a YouTube link on my YouTube channel, by tomorrow. So before I start, what questions do y'all have? What do you want to talk about? What do you want to clarify? Tell me what you want? What you really, really want? Gtp Alk, awesome. Let's talk about that for a second. A lot of people often have questions with that. All right. Let me pull up the PowerPoint slide real quick to make it easier while we go through it. All right. Share. I'm just going to share my desktop. That'll be easier that way. Ooh, that's not what I want to share. Luckily, I don't really have any grades yet. Why is it not coming up? Haha. There we go. All right, so this is the example I used in in the recorded lecture. So when we're talking about Gtp Alk, this is how we're analyzing a woman's obstetrical history. So the G stands for gravida, which is total number of pregnancies, including current pregnancy, just number of pregnancies, not number of fetuses that came out of it. So for instance, if you have twins, it's still just one pregnancy, and it includes the current pregnancy as well. T is for term. So this is any pregnancy that ended 38 weeks and up. And it doesn't matter if the baby lived or the baby died. If it was 38 weeks or later, they are term. Same thing with preterm. The time is what makes the difference. It doesn't matter if baby lived or baby died. Any pregnancy that ended between 20 weeks and 37 weeks and 7 days, that is your term pregnancy. Preterm pregnancy, sorry. Preterm pregnancy. Any pregnancy that ends prior to 20 weeks, whether it be intentional abortion, spontaneous abortion, which is your miscarriage, anything before 20 weeks is abortion. All four of those first letters are based on number of pregnancies alone. It doesn't matter how many fetuses were involved with those pregnancies, or the outcome of those pregnancies. It just matters number of pregnancies, and the T, the P, and the A are all based on number of weeks of gestation, not the outcome. L is living children, so this is currently living children. This is the only number out of all of them that is actually based on a number of children, not number of pregnancies. So let's do this for an example. Our example here is you're caring for a patient. If you've already listened to this, you know the answers, but we can talk through this again. So if you're caring for a patient who is 10 weeks pregnant, her obstetrical history, she's had one set of twins born at 32 weeks, a girl born at 41 weeks, a stillbirth at 34 weeks, and a spontaneous abortion at 13 weeks. How would we lay out her pregnancy based on the Gtp Alk system? So let's count up our G first. So I'll give you the answers.
Miss Martinez, we can't hear you.
So y'all got none of that, did you?
No, the last thing we heard was the answers.
That's okay. Let's start over. Well, that's frustrating. I don't know why my speaker was off because it was on just a second ago. All right. Y'all can still hear me, right?
Yes.
Perfect. All right. Let's try this again. So when we're talking about our Gtp Alk, analyzing...
I cannot hear.
Can y'all not hear me?
I can hear you. I don't know who that was.
Okay. So when we're analyzing the Gtp Alk case study, so this is looking at a woman's obstetrical history, how many pregnancies they've had, what the outcomes of those pregnancies were, and things like that. So in this example, and if you've already listened to the recorded lecture, it's the same example, but we'll walk through it step by step. So the first four letters, the G, T, P, and A, are all based on number of pregnancies alone. It doesn't matter the outcome. It doesn't matter when they ended, or the G doesn't matter when they ended. Basically, living or dead baby, G, T, P, and A, number of pregnancies, not number of children. So it doesn't matter how many fetuses were involved. It's still number of times the person got pregnant. For the G, the gravida, this is number of pregnancies total. Doesn't matter when they ended, doesn't matter how they ended, doesn't matter the outcome, the fact that she was pregnant, including current pregnancy. So don't forget about the fact if she's currently pregnant, that's one of them as well. So when we're talking about T, term, this is any pregnancy that ends 38 weeks and up. In other words, it doesn't matter if baby lived or died. It is still a term baby. So the T, the P, and the A, the term, preterm, and abortion are all going to be, it doesn't, well, abortion, they're not going to be living if they, the term pregnancy terminates that early. But with the term and the preterm, it doesn't matter if baby lived or died. It's time. Time is the big difference in term, preterm, and abortion. Term is 38 weeks and up. Preterm is 20 weeks to 37 weeks and 6 days. And then abortion is before 20 weeks. L is the only letter that is based on number of children, not number of pregnancies. So if you had had one pregnancy but had 2 children, L is still going to be 2 because there's 2 children. Let's go through this one. So you have a patient who, so we'll do the G. She's currently 10 weeks pregnant. That is 1. Her obstetrical history includes 1 set of twins born at 32 weeks. That's 2. A girl was born at 41 weeks. That's 3. A stillbirth at 34 weeks. That's 4. And then a spontaneous abortion at 13 weeks. That's 5. So they all 5 pregnancies had different outcomes and ended at different times, but they're all still a pregnancy, including the one right now because she is pregnant. The T, the term, any pregnancies that ended after ended at 38 weeks and up. So there's only one on here that lasted that long. She had a girl born at 41 weeks, so that is our only term pregnancy that this girl has had. For preterm, again, number of pregnancies, she has 2 preterm pregnancies in this case. She had a set of twins born at 32 weeks. That's still 1 pregnancy. Even though it's twins, it's 1 pregnancy, so that counts as 1. And then she had a stillbirth at 34 weeks. That's 2. Even though baby died, because it's after 20 weeks, it's still considered preterm, not a spontaneous abortion. As far as the spontaneous abortion, A, or abortion, she had 1. The spontaneous abortion she had at 13 weeks. Again, this is based on time. So because it was before 20 weeks, it's an A. It's not a preterm. And then the last one, living children, is 3. This is the only one based on number of children. So her set of twins born at 32 weeks. That's 2 babies. That's 2 children. And then she had a girl born at 41 weeks. That's your 3rd child. Does that make sense? I think you go. Yay! Good. Perfect. What else you got for me? Nothing. Y'all are good? You ready to take tests right now? Not yet? Okay, maybe tomorrow. Symptoms of pregnancy. So there's 3 categories of symptoms of pregnancy. Let me close that. Hold up. Let me find it. It should be further down. So when we're talking about signs and symptoms of pregnancy, again, there's 3 categories. The way they're kind of laid out is presumptive signs are subjective symptoms that are experienced or felt by the mother. Probable signs are objective signs that are observed by the provider. And then your positive signs are signs that are positively related to pregnancy. So a better way to differentiate these, though, is your presumptive signs are more vague, and these are the ones that they are going to be your subjective signs. These are ones that it could potentially be pregnancy. For instance, nausea, fatigue, breast tenderness, amenorrhea. Those are things that in and of themselves alone, maybe, maybe not. Then you have probable. These symptoms are probably pregnancy. In other words, a positive pregnancy test. A positive pregnancy test is only probable, not positive, because there are factors that can cause a false positive on pregnancy test. So it's not 100% without a doubt. To be a positive sign of pregnancy, it has to be 100% without a doubt. There's nothing else that can cause it for this to happen. When you have a fetal heart rate, you put the Doppler on and you hear a fetal heart rate. There is nothing that is going to cause a fetal heart rate but a fetal heart. To have a fetal heart, you got to have a fetus. So therefore, it's a positive sign of pregnancy. If you do an ultrasound and you see a fetus, guess what you got? If you verify fetal movement, whether it be through Leopold maneuvers where you're feeling that movement, or whether it be on ultrasound, verifying fetal movement is a positive sign. If a fetus moves, guess what it is? It's a fetus. So the big difference is presumptive, probable, positive. And there is a chart in your ATI book. I think I wrote it down. Hold on. Page 17 in your ATI book that lays those out, differentiating those. Any other questions y'all got?
I have a question.
Yes, ma'am.
When measuring the fundal height, like how hard do you have to like push down to be able to feel that?
When they are pregnant, especially if they are well pregnant, you don't have to push very hard. Now, what's that? What's that?
And you're just feeling the uterus, the sides of the uterus?
Yep, you're feeling the fundus. Yep, so you're feeling for that topmost part. It'll feel kind of like a firm area at the top of their abdomen.
Thank you.
Absolutely. So the worksheet that I loaded onto, I don't know if y'all saw it. Sorry, day class, I realized what had happened what happened was, instead of loading it to your class, I loaded it to the evening class twice. So I would recommend that you go and print that out and do that to help with your readings, because it is a lot of information that you need, that's important. So let's go over the answers to this for those of you that did it. If you haven't, it will help you as you go back later. Make sure you go and actually read the information surrounding this, though, if you haven't done it yet. X-linked recessive. Is that all you got out of that whole thing? There was a lot of questions on there.
Pregnancy quiz in-class activity?
That's it.
Okay.
All right. So the first question on this worksheet asks, list the 4 hormones produced by the placenta and name one symptom or effect associated with each. So there are 4 main hormones associated with placenta. The one I don't really want you to worry about is human placental lactogen, or in your textbook it calls it the HCS. And don't ask me to pronounce it. The human choreo blah 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 blah. Somatotropin, same thing. HPL, HCS, same thing. Don't really focus on that one too much. So the 3 I do want you to focus on, though, is human chorionic gonadotropin, which is your HCG, which is what we detect in pregnancy tests, estrogen, and progesterone. Those are the big hormones you need to know. So HCG, or human chorionic gonadotropin, acts kind of like the master hormone of the placenta. So the function of HCG is to keep telling the placenta to produce estrogen and progesterone so it can maintain the pregnancy. So it's like the command center. And that is why that is the hormone that we detect in pregnancy tests. Oh yeah, I guess I don't need to share my screen anymore. I'll come back to it if I need to. So this hormone is telling the placenta to release those other hormones. And it's the one we detect in pregnancy tests, and it has different levels per week. So usually in the first trimester, it's pretty significantly high. And then as that pregnancy becomes more established, those numbers will progressively drop. When we have patients that come into the ER with vaginal bleeding or whatnot, and you suspect they may be having a miscarriage, we'll do what's called a quantitative HCG on them, where we're actually getting an amount, not just a positive, negative, like on a urinalysis strip. And this will tell us potentially if they're losing the baby, if that number is significantly lower than what we would expect it to be based on their week of pregnancy. So this is like the command center type of stuff. Progesterone and estrogen are 2 big ones because they maintain. Progesterone is the hormone of pregnancy. It is the main hormone that maintains a pregnancy. So the way progesterone works is it calms everything down. It keeps that uterus from contracting. So when a egg is first fertilized and implanted into the uterus just sees that as a foreign body. It doesn't realize that you want that to be there. So it's going to try and contract to push that egg out. Progesterone is there, as you saw from our week 1, the recorded lecture I did where I showed the hormones, how they go up at the second half of the menstrual cycle and kind of stays up to, hopefully, if an egg gets fertilized and attached, it will be up, and then if there's no fertilized egg, it drops back down. Well, then when that egg attaches, it stays up to maintain that pregnancy. It decreases muscle contractions and calms everything out. The problem with progesterone is it works great for that, but it also calms a lot of things down, like your intestines. So this is one of the reasons women get constipation so easily with pregnancy, is because it calms down those intestinal walls as well. Estrogen is responsible for uterine growth. So it increases venous congestion. That's the word I'm looking for. It increases the blood flow, basically. It is what stimulates them to retain water. 50% extra fluid is on board. It causes vascular congestion to sites, and what it does is by pulling in all that extra blood, the more blood the uterus gets, the bigger it can grow. That's the purpose of it, but because it's trying to promote growth of the uterus, it also causes some side effects like Chadwick's sign, which is the bluish discoloration of the vagina, from all that vascular congestion. It also causes nasal congestion, nosebleeds, and things like that because, again, all that extra blood flow is everywhere, not just in the pelvic cavity where the uterus is. So they'll get stuffy nose and nosebleeds and things like that from it. The next question has to do with how much weight a woman should gain during pregnancy. So what's the normal? If they have a normal BMI, how much should they gain? 25 to 35. Perfect. So somebody who is of average BMI or normal BMI should gain 25 to 35 pounds over the entire course of the pregnancy. Normal BMI, and this you can find this in your nutrition book. It doesn't talk about BMIs actually in your maternal newborn book, but it does have it in your nutrition ATI book. 18, God, my throat is dry today. 18.5 is the minimum, and then 24.9 is the maximum. So if they fall within those two BMIs, they are considered normal BMI. If they are less than that, then they're underweight and they need to gain more weight. If they are overweight, then they need to gain less weight. But that 25 to 35 is the big one you need to know. I see you typing. That's why I'm waiting. No pressure. Yep, exactly. 15 to 25 over, 28 to 40 if they're under. Very good. All right, so the next question has to do with the possible, probable, or presumptive, probable, and positive pregnancy symptoms, which I already went over that with y'all. Again, that is on page 17 in your ATI book. So it has a nice little chart there that lists those symptoms, so you can look at the difference in the three categories. The next question has to do with Naegele's rule. Naegele's rule is what we use to determine estimated date of delivery. So based on the first day of a woman's last menstrual period, we count up 9 months and we add 9 months and we add 7 days. I know the book talks about subtracting 3 months and adding a year, which sometimes students get confused with that because they'll subtract the 3 months but forget to add the year, so it leaves it in the same year, or leaves it a year behind. So I think it's easier just to add 9 months and add 7 days. Let's say, for example, you have a woman whose last menstrual period was February 7th. So when you take February, June 25th of, on the PowerPoint, let me go back. I honestly can't remember what example I gave. Oh, on the one on the worksheet. Listen to me. Yes, June 25th, 2019. That is correct. Very good. So, there's two ways you can figure this out. You can use numbers to help you figure this out and do it as a math calculation. For instance, in this case, if you have September, If you add 9 months to it, it gives you 18. There's no 18 months in a year, so 18 months minus 12 is 6. That's your 6th month, June. I like finger counting. So you start with September, October, November, December, January, February, March, April, May, June. Either way is fine. I find it easier, and I'm more likely to get it right when I count on my fingers. But either way will work. So the next question on the worksheet is the Gtp Alk, which is we just went over. Does anybody have any difficulty with that? It's very similar. The one on the worksheet, a couple of the numbers are a little bit different, but the answer ends up the same. Okay, good. Nairetta, are you talking about the answer to the Nagel's rule? It's June 25th, 2019. Oh, to that one, it should be the answers you should have gotten were 5, 1, 2, 1, 3. No, preterm is 20 to 37 weeks and 6 days. Term is 38 weeks and up. No problem. Basically, remember those numbers for abortion, preterm, and term. Don't think about the outcome, whether it was a living child or a stillbirth or an abortion. Think of it as when did it happen. A large majority do, yeah. Most women, although I feel like I hear people that are preterm all the time. It's fairly common to have preterm babies. They're not always babies that go to the NICU or have complications. Mine wasn't. I mean, mine was 34 weeks and she went right home with me in 2 days. No NICU, no extra anything. Oh my gosh. 4 weeks. Oh no, there's no way. I'm actually surprised they let your mom be pregnant that long. Normally after 42 weeks they don't let you go any further because they can cause fetal distress because the placenta starts breaking down. But you know, back when we were all born, that was a different time than now. That's why she waited 14 years. Yeah, I don't know that I blame her on that one. I think that would have been it for me. But you know, it's funny how pregnancy, as soon as postpartum gives you amnesia, you forget the pregnancy and the labor and all that stuff afterwards. It's evolution's way of maintaining the species, I think. All right, so the next question was identifying situations which a patient should be referred for genetic counseling. So on page 35 in your ATI book, it talks about these reasons. under where it's talking about amniocentesis and indications for amniocentesis, it talks about ways that that point to the necessity to get genetic testing. So some of the reasons that patients would be referred for genetic testing include if they already have a child with a disorder. So if there's a sibling to this baby that has a disorder, if one of the parents either has a disorder or they're a carrier, like sickle cell, for instance, people can be carriers, or cystic fibrosis even. Both of those, they can be carriers and not have the disease, but you'd want to see if baby has that disease if they got it from both parents. If mom has had multiple miscarriages, so one thing that is often the cause of first trimester abortions is some kind of genetic defect. And the body recognizes there's a genetic defect and aborts that baby. If mom keeps having miscarriages, it could be because either her or the father are passing down some abnormality in their cells that is causing it not to work out to be a compatible union. So if mom has had multiple miscarriages, they'll look at that. They'll look at genetic testing as well. Another thing that they will use genetic testing for is if they have an abnormal alpha-fetoprotein level. So for day class, we talked about that today. For tonight, those of you that have me tonight, we'll talk about AFP in a little bit more detail. But basically, it's a blood test that detects things like Down syndrome and spina bifida. So if that maternal AFP level comes back abnormal, then they may do an amniocentesis to get further detailed genetic testing, like with Down syndrome, for instance. So next question, name 2 immunizations that should be administered to a woman with every pregnancy. Every single pregnancy, they should get Tdap and they should get flu. Very good. Flu and Tdap. And this is not for the benefit of mom. I mean, we don't want her to get flu. But even if she just had that Tdap 2 years ago in her last pregnancy, she should still get one because it will create antibodies that will be passively given to the fetus to help that fetus fight off any exposure that happens before they're able to get their own vaccinations. Tdap, they don't get their first vaccination until 6 weeks to 2 months, depending on when that first vaccination visit is. And then flu, babies cannot get flu vaccine until they're 6 months old. So this helps give them some kind of protection before they are old enough to get those vaccines. The ones that they should not get that are absolutely contraindicated during pregnancy, the big ones are MMR and your varicella. Very good. So your measles, mumps, rubella, varicella are all live vaccines. And I didn't realize this, but apparently the ATI book also lists HPV. But MMR and varicella are the big ones to focus on. They're live vaccines, so they have the potential to cause complications to the baby if the baby gets exposed, being a live vaccine. One of the things we'll talk about tonight, or that we talked about today if you're in the day class, is torch infections. And one of the torch infections is rubella. So it can cause potentially long-term serious complications if they're exposed to it. Now, the rubella vaccine, we want mama to get as soon as she gives birth, as soon as that baby pops out, not literally as soon as, but before she goes home from the hospital, she should get that rubella vaccine. So genetic probability, everybody's favorite. Mine too. So we have 2 types of gene cells. We have autosomal and we have your X-linked. So autosomal is all the rest of them. So, and then when we break those down, they can be recessive or dominant. So when we're talking about recessive diseases, in order for there to be in order for a disease to show up, they have to get that defective gene from both parents. Sickle cell is a great example of an autosomal recessive disease. In sickle cell disease, that's why you have some people that are considered carriers, or they'll be categorized as having sickle cell trait, but they don't actually have sickle cell disease. They have one gene of the abnormal sickle cell gene, but you need two to actually have sickle cell. So they can still pass it down and carry it to their offspring, but they will not actually have the disease. So recessive means you have to get it from both parents. So when we're talking about recessive disorders, those have a 25% rate of potentially having a disorder because you have to get the defective cell. There's a 25% chance that you'll get it from both parents. Versus dominant is a 50% chance, because when it comes to dominant disorders, you only need one. So if you have one parent that's affected and they pass on that defective gene, then that's a 50-50 chance they're either going to pass on the good gene or the bad gene. It doesn't really matter what the other one passes on. And then when we're talking about like X-linked recessive, specifically X-linked recessive to focus on it, these are pretty much exclusively in boys. And the reason for that is because boys don't have a second X to offset their that defective X. So when it is passed on an X gene and that X is defective, if they have a Y that goes with it and not another X to calm it down and neutralize it basically, then you will see that. So with girls, they'll have one recessive defective gene, but they have a normal X, so the normal X is gonna come out. So really, don't go into too deep on genetic probability, just kind of the overview of it. And how we would teach our patients. How would we teach our patients what they need to know as far as what's the chance that my child will get cystic fibrosis, for instance? How do you talk to your families about that? So the next question has to do with danger signs of pregnancy. So in your book, page 177 in your textbook, 24 in your ATI book, it talks about the danger signs of pregnancy. No, a male is still 50% because so page 177 in your textbook or page 24 in your ATI book, those are the ones for the danger signs of pregnancy. Something else that's really good for you to look at in your ATI book is where it talks about common discomforts of pregnancy and how you can alleviate those. That's important for you to review, and that is on page 23 in your ATI book. So when we're talking about genetic probability, males would be 50%, because if you've got mom who has two X-linked genes, or you've got dad that's got one X-link, dad's not passing along an X because you're creating a boy. So it's coming from mom. She has two genes. She has good X and she has bad X. There's a 50% chance she's going to pass along good X, and 50% she's going to pass along bad X. So males would have 50%. Females, they consider pretty close to 0%. It's not completely zero because there is a potential you could pass on two X's, but a lot of times when you have those type of diseases, you don't see them passed on in that way. So pretty much you might as well say 0 for females. No problem. So some of the things that are danger signs in pregnancy. Some of them are obvious. Some are not so obvious. Probably the biggest one that you should know is change in fetal movement. And what this means is a baby was kicking and playing and moving all about. yesterday, and now all of a sudden mom realizes, wait, I haven't felt the baby move in 6 hours. That's a problem. They need to seek healthcare and figure that out. The minimum, when patients are doing fetal kick counts, where they're actually, usually only see this with high-risk pregnancies, they sit there and actually count the number of times they feel baby move in an hour. The minimum, absolute minimum, is 3. If they don't feel that baby move at least 3 times, they need to seek health care. So change in fetal movement, convulsions, that's kind of an obvious one. If they're having seizures, they need to go see somebody. If they are having severe headaches or blurry vision, severe headaches, especially ones that are not relieved by something like Tylenol, they should seek health care. If they are having edema, but it depends on where the edema is. So a dependent edema that patients get in their feet and their ankles is very common in pregnancy. I don't know that I've ever known a pregnant woman who didn't get even just a mild case of edema in their feet and ankles. Common, expected, normal. What's not normal is if they get swelling in their hands or in their face. Those are indications of potentially preeclampsia. So making sure patients know the location of their swelling is important. Anytime they have vaginal bleeding, especially now you have patients, for example, if they have placenta previa, they may know their vaginal bleeding is expected and different, but especially if they don't know what the cause of it is, if they're having cramping or if they are having what feels like contractions, especially if they are getting progressively worse or progressively closer together, that should be investigated. If they have fever, chills, dysuria, painful urination, all those things. So things that should be assessed at every prenatal visit, every single routine prenatal visit, there's actually 4. And there are some things we assess routinely that are still routine, but it's not every visit. For instance, usually once trimester, they'll get an ultrasound. Every time they go to the doctor during between 18 and 30 weeks, usually they'll do the fundal height. But at every visit, from beginning to end, they will check O8, they will check vital signs, they will check a fetal heart rate with the Doppler, and they will check a urinalysis. So those are the 4 things they are checking every single time women go for a prenatal visit. Just routine. I don't remember what the first one was I said. All right, so let me just go through them again. Weight, vital signs, fetal heart rate with the Doppler, and urinalysis. Because I don't know when I said what. Yep, weight, vital signs, fetal heart rate, urinalysis. So the next question, possible side effects related to use of substance abuse or substance use. So there's cocaine, tobacco, alcohol, oh my, alcohol, and opioids that were listed on the sheet. So those are kind of the big ones we focus on. So cocaine and tobacco have very similar outcomes related to the vasoconstriction they cause. So because they both cause vasoconstriction, they decrease blood flow to the baby. And when this happens, it reduces the nutrients that are getting to the baby, if you're talking about over a long-term thing, like where it's a daily use. It also decreases oxygen getting to baby. So even with one-time use, that can cause baby to start decompensating because they're not oxygenating well. Over long term, because of reduced oxygenation as well as because of reduced nutrition, the babies can get IUGR or intrauterine growth restriction, where they're small for their gestational age because of not getting what they need to grow. One thing in addition that tobacco can cause is cleft palate, cleft lip and cleft palate. Yes, tobacco and cocaine. Think of vasoconstriction with those, and think of things that can happen with vasoconstriction. So alcohol causes fetal alcohol syndrome, or FAS. You'll see it abbreviated for short. So fetal alcohol syndrome causes craniofacial abnormalities, where they have they have different facial and head characteristics. For instance, they often have very large foreheads. They'll have low set ears, slanted eyes. There's a few different characteristics that kind of go with it, as well as they'll have mental disability. So they'll have mental impairment related to it, developmental delays and all. And then with opioids, so if mama just partook in some kind of opioid right before giving birth, whether it be she got some morphine for labor or she's been using heroin, baby can have the same type of symptoms like adults have. Respiratory depression. So if they have had, or if they've been exposed to those opioids recently after birth, or recently before giving birth, then watching for that respiratory depression. Over long term, if they've been exposed, they can get withdrawal symptoms. So these symptoms will be very similar to adults in some ways, as far as the tremors, the irritability, things like that. Another symptom that they have is this high-pitched cry. Their appetite is terrible. They often have, I mentioned, the jitters or the tremors, as well as diarrhea it can give them, sweating. So there's lots of symptoms that kind of go with withdrawal. So skin changes that occur in pregnancy. There's several that are listed in your book. Some of the big ones, cloasma or melasma, you'll see it called as well. This is where they get the darkening across the face. They'll call it the mask of pregnancy. A lot of skin changes are hyperpigmentation issues. So the darkening of the face, they'll get the linea nigra, where it's the dark line that goes vertically down the abdomen. Some women get it, some women don't. They'll get spider nevi, or angiomas, the little spider veins. They'll get palmar erythema, where they get redness on the palms and sometimes on the plantar surface of their feet as well. They'll get pruritus, especially along the abdomen as that skin is stretching. So there's various different skin abnormalities that you'll see. It's important for you to be able to differentiate normal skin abnormalities or normal skin alterations versus something that's abnormal that warrants attention. So food sources for iron, folic acid, calcium. These are on page 27 in your book, in your ATI book. Hopefully y'all know these by now, since you've had nutrition and the like, but you might need a refresher. So you need to know sources of iron, folic acid, calcium. So folic acid, iron have some similar ones, like the red meats and stuff. Then they have some different ones, like black beans, for instance, is a great source of iron. And also knowing what they should take with it. For instance, it's good for them to have some source of vitamin C when they have iron food sources. And it doesn't have to be drinking orange juice, for instance. It can be eating citrus fruits, like eating a grapefruit, eating an orange, things like that. And then with calcium, milk's obvious. Everybody knows milk products, but don't forget about leafy greens, in your there's a fish, salmon, that has good calcium sources. All right, so functions of amniotic fluid. There's several functions. So one big function is protection. Protection from injury. It allows baby to float around in that area and keep that baby from getting injured. It protects from infection by creating this closed area. It protects from temperature changes. So it maintains an even temperature. So baby doesn't get subjected to drastic changes in temperature. What's another one? Oh, it keeps baby from sticking to the wall of the amniotic sac. Babies have very friable skin, especially when they're preterm. If you care for a preterm baby, you can literally put your hand on them with your gloved hand and peel their skin off if they're super preemie. You have to be very careful. So if they don't have enough fluid and they get stuck to that amniotic sac wall, they can actually stick to it, and it would just pull their skin off. It allows for symmetrical growth. So if there's not enough fluid and baby is scrunched up against the wall of the amniotic sac, they're not going to grow on that side that's wedged up against the wall. They're going to grow differently on the side that's open out to the area. Yes, provides lubrication so they don't stick to that wall. Yes, the umbilical cord, that was the other one. So it decreases the risk of nuchal cords and cord compressions because it allows that cord to float within the fluid. If there wasn't enough fluid, it can get clamped down in between baby and the structure it's up next to, whether it's the wall of the uterus or whatnot. So it helps prevent that cord compression. Sometimes when you have women that are going to go into labor, or that are already in labor, I should say, and you need to put some fluid up in there because they don't have enough fluid, you can do amnio infusions where they'll put a catheter up in the uterus, and then obviously you have to break the amniotic sac first, and you can infuse fluid up in there so it gives some kind of almost like a water slide for baby to be surrounded by so that cord doesn't get compressed. So how we do fundal height. So fundal height is done between the weeks of 18 weeks and 30 weeks. And they start at the top of the pubic bone, and then they measure all the way up to where the fundus of the uterus is. So the top of the uterus. And they measure in centimeters, and whatever it measures in centimeters should be pretty equivalent to where they are in their gestation, with a 2 centimeter leeway either way. So for instance, if you have somebody that's 24 weeks of gestation, you would expect it to be somewhere between 22 and 26 weeks. So from the top of the pubic bone to the uterine fundus. All right, so the last question talks about testing procedures, routine testing procedures, when they're done, and what they're for. So one of the big ones we talk about is amniocentesis. Our purposes of amniocentesis we talk about today is going to be a little bit different than what we talk about for next week. There's 2 different times that amnios are done. The one we're talking about today related to pregnancy has to do with genetic testing. And typically that's done around 14 weeks of gestation because you got to make sure that there's enough amniotic fluid there to actually draw some out. And they stick a needle through the abdomen, through the uterus, and which draw some amniotic fluid for genetic DNA testing. They can determine gender from this, but they're not going to do this just to determine gender, because it is a highly risky procedure. Yes, thank you. All right, so the Coombs test. What they're doing with the Coombs test, it has to do with patients when you're worried about Rh factor, like with mamas that are Rh negative, babies Rh positive, that kind of thing. And the Coombs test is testing for sensitivity to see if they've been sensitized to positive blood. It's done initially at the beginning of pregnancy, and then they'll do it again at 24 to 28 weeks to make sure that mama's not trying to produce antibodies against this blood. So we'll talk about Rh factors in class tonight. For the night class, for the day class, we already talked about it, that we give Rh factor at 28 weeks after they've been retested, and then we give it again right after they're born within 72 hours, so that way it prevents mom from creating antibodies. What we worry about with the creation of those antibodies is not this current pregnancy, it's the next one. If mom creates antibodies and they are floating around in her system, next baby that she has, those antibodies will attack that baby because they recognize it as foreign, because they've created antibodies against this foreign Rh factor. So it will cause mass hemolysis to the baby's blood. So one that we talk about quite a bit is the Maternal Alpha-Fetoprotein, or AFP. I mentioned this a little bit earlier. So this is typically done around 16 weeks to anywhere from 16 to 28 weeks. Just depends on what they're looking for. And this can give us some ideas of a couple things. If they're too low, it may indicate Down syndrome. If it's too high, it could indicate, usually it indicates something didn't close properly. The most common thing we look at is spinal defects like spina bifida, but it can also indicate things, something called gastroschisis. I typed it in, so I'm not going to spell it out verbally. So gastroschisis is where the abdominal wall does not close all the way. So there's an opening, and their intestines are actually on the outside of their body, enclosed in a membrane. So that can be another cause for it to be too high. So think of it as an anatomical defect where something didn't close properly when it's high. When it's low, it's Down syndrome. So think low Downs. Oh, another one it causes is bladder exstrophy, or extrophic bladder. So when we're talking about bladder exstrophy, this is where the bladder is on the outside of the body. So when baby's born, that bladder is just sitting there on top of their skin, enclosed in a membrane. And the last one that's listed on here is group beta strep, or group B strep. This is not strep throat strep. That is strep A. This is very common to live in women's vaginas for, it is kind of almost like a normal flora. It doesn't cause any problems. It just lives there hanging out. And you wouldn't be concerned other than you're concerned for the fetus. So if baby passes through the birth canal and mama has that infection, baby can pick it up and get neonatal sepsis. So this is routinely tested on every woman between 35 and 37 weeks. And if it's positive, they will treat the mom with IV antibiotics while she's in labor. Ideally at least 4 hours before giving birth, so there's time for the medication to kick in. So what if Mama didn't make it to 35 or 37 weeks. What do we do about it? What do y'all think? We can give antibiotics to baby after birth, but a lot of times they'll just prophylactically treat the mom. Like I told you, my baby was born at 34 weeks. At that point, I hadn't been tested yet. They did not know my GBS status. So instead of waiting and finding out and potentially having complications, they just gave me the antibiotics while I was in labor, just in case. Yep, we would still treat her. Still treat her anyway if you don't know. Typically, for most patients, it's ampicillin. If they have a psyllin allergy, usually the next course of choice is vancomycin. Any questions on any of that? If you haven't done it, go back and look at it, especially with your readings. Good. I'm glad. All right. I see you typing. Good. I'm glad. I like worksheets too. They help. I'm a firm believer in active reading. If you just read, and even highlighting is not really, and I know this as a student. I've been there. You read 50 pages of something. You're highlighting, you're being meticulous. You think, yeah, I'm getting the good stuff, and you get to the end and you're like, I do not remember a thing I just read. So it just kind of goes through. Reading, I agree. I struggle with, I love to read as far as reading for pleasure reading, but when it comes to like detail, or I enjoy reading research articles or reading things that are interesting, but yeah, textbooks are not always fun, but they're necessary. They're definitely necessary to read, especially the higher up you get. If you've gotten by so far without reading, you're going to struggle this semester. Whether it be my class or Mr. Dobbins's class, this is definitely a semester you can't get by without some level of reading. All right, let's play a game real quick. Let me pull it up. This is a short one. I'll have a long one. Not for this one. All right. There you go. There's your code. Go for it. Here we go. There you all are. Oh, we're losing people. Where's everybody? It shows me there are 18 people in here, not including me.
Miss Martinez, I'm just listening because I'm in the car driving from work.
Oh, you mean you can't play in the car? Please don't. I'm just kidding. Oh, Michaela. Did Ashley take all your connection? So the PIN is that 7-digit number at the top, that 1930106. And we got most of y'all. There you go, Natalie. Perfect. All right, let us begin. And if you're still trying to get in, it's okay. You can jump on in at any time. 15 questions. Let's see how you do. All right, what symptom, and if y'all don't get this, I swear, what symptom differentiates placenta previa from placental abruption? Is it bleeding, hypertension, pain, or proteinuria? Actually, night class I can understand because y'all haven't covered it yet, but day people should know this. Pain. So the biggest difference between placenta previa and placental abruption is whether or not they have pain. Yes, you have to look on the screen to see the answers. So on my screen, the screen I'm sharing with you is where it shows the answers. It says it's sharing. Can anybody else see the? Do y'all see that? Okay. Gotcha. So what do y'all see right now? Do you see the black Skype screen or do you see the Kahoot screen? Okay, so it must be because I went back and forth between the screen. So let me go back to that one. And I'll stay on this screen so that way it doesn't mess y'all up. Because I thought it would only share this screen and dang it. Sorry. Okay, so let's talk about this. So the difference between the two is pain. So with placenta previa, you're not going to have pain. It's going to be painless. Placental abruption is painful. Now, both of them you do have bleeding with, but there is a difference in the type of bleeding. Placenta previa, you have light bleeding. Light colored bleeding or bright red bleeding. And then you have with the placental abruption, dark red bleeding. But pain is the biggest difference. All right, all of the following are complications of bed rest or impaired mobility, except what? Atelectasis, diarrhea, depression, or thrombosis. Which one is not a complication of impaired mobility or bed rest? Take yourself back on a trip to fundamentals. Yay! Diarrhea. You wouldn't have diarrhea, you would have constipation potentially of bed rest. So going back to fundamentals, you talked about more related to impaired mobility, but because we're going to be talking about things like placenta previa and preterm labor, those are methods that require sometimes bed rest. So we have to look at those complications of being on bed rest, similar to impaired mobility. It's not because they can't move about, it's because they're not allowed to get up. So, but they can still have the same complications. That atelectasis, where their alveoli kind of start to wither down and they're not getting as good of gas exchange. Constipation because of the slowing. They'll get urinary retention. They'll get DVTs, thrombosis. They'll also, don't forget about psychosocial. We always focus on the physical. Don't forget about the fact that they can get things like depression and all from the isolation that being on bed rest causes. All right, which of the following is not a hormone produced by the placenta? Is it HPL, testosterone, HCG, or estrogen? Which one does not fit? Yay, good job, guys. Testosterone. So the other three that are listed, the human placental lactogen, the human chorionic gonadotropin, and the estrogen, are all hormones that are produced by the placenta. The only one that's not included here that's also produced by the placenta is progesterone. So that one as well. Testosterone is not. All right, which of the following types of abortions would include bleeding with a closed cervix? All right, day class, we talked about this. Inevitable, missed, threatened, incomplete. I know, you're like, really? We just talked about this like an hour ago. 2 hours ago. It's like stair steps. So when we're talking about a closed cervix, this is a threatened abortion. So what is happening with a threatened abortion is the woman is having vaginal bleeding, which indicates a problem. But when you look, the cervix is still closed, which means it's a threat. It doesn't mean it's definitely going to happen. There may be potentially, depending on what is causing this abortion, to stop it from happening. So it's a threat. There's a potential, but it hasn't happened. The cervix is still closed. And it does go through in your ATI book describing those different types of abortions. Which of the following has hallmark symptoms of dyspareunia and worsening pain with menses? This is from the menstrual disorders recorded from last week. Is it dysmenorrhea, endometriosis, PMDD, or PID? Endometriosis. So dysmenorrhea just means painful menstruation. So that's what the worsening pain with, that's just describing that pain. That's what the term means. Endometriosis is where there is tissue that is endometrial tissue that's supposed to be inside the uterus that gets outside of the uterus. So it implants to the outside of the uterus. It can implant to the abdominal wall. And it reacts just like tissue that's inside the uterus. It contracts and things like that. So they'll have worsening pain with menses. They'll also have painful intercourse. 2 hallmark symptoms. All right, all of the following except for this can contribute to preterm labor. Bacterial vaginosis, urinary tract infection, moderate exercise or dehydration. Which one would not contribute to preterm labor? Great job, y'all. So moderate exercise. Moderate exercise is a good thing. We encourage women to participate when they're pregnant in moderate exercise, as long as it's not more strenuous than they're used to. The other three, bacterial vaginosis, urinary tract infections, dehydration, all of these can increase the risk and actually send a patient into preterm labor. This is one of the reasons we promote treating infections as soon as they happen in pregnant women, as well as pushing fluids. Which of the following symptoms is related to HELP syndrome? So edema, jaundice, proteinuria, or convulsions. Remember, not related to preeclampsia, related to HELP. Oh, jaundice. So when we're talking about preeclampsia, and for the night class, we're going to talk about this in more depth during class. So preeclampsia, one of the secondary complications that you can get when you have preeclampsia is HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. So edema and protein in the urine is not related to HELP syndrome, it's related to preeclampsia. Now, might they have these symptoms if they have HELP? Yes, but the HELP is not what's causing it, it's the preeclampsia. Convulsions is related to your eclampsia. So jaundice, because of the mass hemolysis they're having, is going to cause that jaundice. So what is the minimum number of fetal movements that should be felt per hour for a fetal kick count? I mentioned that one. 3, 6, 12, or 30 minimum. Great job. Minimum is 3. Typical is around 30 an hour, but the absolute minimum is 3. Less than 3, we got a problem. Which of the following would be a probable sign of pregnancy? Fatigue, abdominal enlargement, breast tenderness, or fetal heart tones? Which one is probably? Great job. Abdominal enlargement. So when we're talking about probable signs, these are ones that are not 100% without a doubt caused by pregnancy, but they're highly suspicious. They're probable. So fatigue and breast tenderness are your presumptive signs. They are subjective, felt by the woman, more vague. Fetal heart tones is a positive sign of pregnancy. There is absolutely nothing else that can explain a fetal heart tone except for the presence of a fetus. Abdominal enlargement, a large majority of the time, especially based on the presentation of the abdominal enlargement, suggests pregnancy, but it's not 100%. All right, what tests would be used to determine fetal well-being if non-stress test is positive? Sorry. Ultrasound, amniocentesis, biophysical profile, maternal alpha-fetoprotein. What would be our next step if our non-stress test we are not happy with? Biophysical profile. So a non-stress test is where we have mama sit there and we hook her up to a fetal heart rate monitor, and just sitting there, what is baby's heart rate doing? Is baby having decelerations, which when we cover next week, decelerations will make more sense. If they are dropping their heart rate, so positive is a bad thing. This is one of those things that we don't want our tests to be positive. A non-stress test should be negative. Think negative normal. N for N. Negative is normal. Positive means they are positively dropping their heart rate. So if they are dropping their heart rate and we're concerned that they are not tolerating being in utero anymore very well, the next step is to do a biophysical profile where through ultrasound we can look at the different characteristics and give them a score and add it up. So we'll look at things like how much amniotic fluid they have, their muscle tone, and things like that, and put all of it together to give us a score, to give us a more objective number to put on how well they're doing. Which of the following would be associated with herpes? Pain-free canker lesion, clusters of vesicles, cauliflower lesions, or green foul-smelling discharge? Which one is herpes? Kind of straight across the board. So make sure y'all go back and review your STIs. You're going to need to know symptoms as well as treatment. It seems easy. A lot of times people just don't bother to study this. I'll be honest. People have told me. I didn't study that part because it seemed easy. But there are a lot of STIs listed with symptoms and management. So make sure you learn those. Don't just breeze over it. So herpes is associated with a cluster of fluid-filled vesicles. So if you've ever seen shingles, it can look kind of similar, except it's on mucous membranes instead of just skin. The other ones, pain-free canker lesion is your syphilis. The cauliflower lesions is your genital warts. And the green foul-smelling discharge is your trichomonas. Which puts the patient at risk for a polyhydramnios, macrosomic infant, and miscarriage? Day class, you better get this. Smoking, diabetes, hypertension, or cocaine use? Great job. Diabetes. So the polyhydramnios and the miscarriage can be caused by multiple things, but the big key word here that you should associate with diabetes whenever you see it is when you have macrosomia or a macrosomic infant or a large infant. Which of the following is associated with dark red prune juice vaginal discharge? Ectopic pregnancy, hydatiform mole, placenta previa, or placental abruption? Good job, hydatiform mole. So this, you'll also hear it called a molar pregnancy. You'll also hear it called gestational trophoblastic disease. What this is it's not a fetus. It is a cluster of cells where an egg and a sperm came together, but something was wrong with one of them. So instead of creating a fetus that differentiates into different specialized cells, it just rapidly reproduces these just undifferentiated cells. So it's just this big cluster of cells. So that dark red or brown prune juice vaginal discharge is what you'll see. So red or brown prune juice. Which of the following is not associated with increased estrogen in pregnancy? Nasal congestion, Chadwick sign, hypertension, or epistaxis? Which one doesn't fit with estrogen? I gave y'all these when I went over the worksheet. If you remember, it was like the first question. Good job. Hypertension has absolutely nothing to do with it. Nasal congestion, Chadwick's sign, epistaxis, all of those are related to increased estrogen. Because of estrogen's effects on increased blood flow and increased vascular congestion to pull more blood to the uterus so that the uterus can grow more rapidly, it also causes this increased vascular congestion throughout the body, including in the upper airway and in the vaginal area. Vaginal. Oh my gosh, what did I just say? Sorry. Which of the following should be done to prevent Vena Cava syndrome? Side lying, increased fluid intake, ambulation, or increased protein intake? Excellent. Everybody got that one. So Vena Cava syndrome, you'll also hear it called supine hypotension. Any woman who is, by the time they get to their second trimester, should not lay on their backside flat. They should lay on their side because that baby presses down on that vena cava, causing compression, decreasing venous blood return, and making them dizzy. So if they're dizzy, turn them over. Good job, guys. Whee! Alrighty. All right, any questions that I can answer? Make sure you're reading. I know we've had our discussion about how exciting reading is, but it is absolutely important. I love tutoring too. Aww. Wait till you get to class. I'm even better. I don't know about that one, but Peds RN teacher. So I'm glad you asked, Jamaica, because they are public. They're not private. So Peds RN teacher is my Kahoot username. So the way I recommend reading, I recommend both because there are going to be things in the textbook that it emphasizes on that they don't really go into as much detail with ATI. Here's how I would recommend your process of reading. Start with the ATI book. Read ATI first. ATI has got bulleted. It's more concise. It's a good starting out point. From ATI, I recommend going to the textbook and reading the big stuff, the tables, the graphs, the little like safety boxes, all those things that are not in paragraph form. Then I would recommend that you read all the paragraphs, but if you don't have time, at least go back to the ones that are in paragraph form that maybe you had some confusion with from reading ATI. If there was something you read in ATI and you're like, they really didn't go into detail, I don't know what they mean, definitely make sure in the textbooks because they will correlate, but the textbook is going to be more detailed. So ATI is almost like a Cliff's Notes kind of thing where it's more bulleted, direct, and then the textbook will kind of expand on it even deeper. Perfect. That is one thing I like about Skype over Blackboard. I can see that y'all are typing, and I know that, you know, I'm not just sitting here while y'all are just staring at me. Good, good. That helps you kind of narrow it down, and use the PowerPoints too, because if it's not in the PowerPoint, it's probably not something we're going to focus on. I'll give you an example in the PN book. I know y'all don't have the PN book, but in the PN book, and those of you that had me, because there's several of you in this class that took my PN class, that book, I don't know what was up with that book. There was a whole like half a chapter that talked about how to have sex, basically. We are not going into that, so that was something you could just gloss entirely over and not even read. So use your PowerPoints to also gauge the big important stuff as well with doing your reading. Peds RN teacher. You're welcome. You'll take the quiz on Blackboard, so it will open up on Blackboard at 6:30 when we start class. Yes, math will be on every single test, just like every other class. Are you talking about maintenance fluids? Because we haven't done maintenance fluids yet. I had mentioned before, maintenance fluids will cover in pediatrics. Are y'all questioned out? That's good. Glad you feel a little bit better. Now, after next week, you might not. I'm not going to lie. Labor and delivery is a beast. if you never read again the entire semester, you have to read before next week. It is a lot of analytical. You need to learn your veal chop, how to analyze your fetal heart rate interpretations, fetal positioning. Next week is a very difficult lecture with a lot of information. Many have said it's probably the hardest one of the whole class. Some would disagree, but next week is you've got to read and be prepared for next week, or you will be lost before we even begin. Yes, all that stuff that takes place in labor and delivery. The veal chop. Memorize veal chop. It will help you. I have students that have long graduated that said they still think about veal chop, and they're not even working in labor and delivery. So which part about veal chop, Trisha? Yeah, exactly. There are tons of questions on ATI, on my exam, and just in general that you're going to see on about that veal chop mine. It lays it out for how based on what is your interpretation. What does it mean? What do you do about it? I posted, or I will post a link. I haven't done it yet. I'm going to post a link to a practice game that's online. It's not really something that is easy to play in class. So I posted it so y'all can play it on your own, where it's got tons of practice strips, and you go through the strip and you identify, is this a variable D cell? What kind of D cell? What is the baseline heart rate? And it helps you just practice when you're looking at those strips. What do they mean? There's also going to be, I've already posted this in your week 4 folder. I posted several videos. I posted a worksheet on fetal positioning. So there's several resources there. So make sure y'all are using those. You're welcome. Alpha-fetoprotein is typically done, oh gosh, 18 weeks, 16 weeks. It's towards the end of the mid to end of second trimester. 18 weeks to, I believe, 28 weeks. The biggest thing is not so much when you do it, but why you do it. You're welcome. All right, y'all. So I'm going to let y'all go for the day class. I will see y'all either in clinical, or I'll see you next week. Night class, I will see you in about 45 minutes. Good. I'm glad it was. See y'all later.